is recording. So as always, if we can just put in the chat bar where you're from, who you are, where you're from, just so I can gauge who is in the room. Awesome. So we've got Rumble. So what else have we got? Pontypool, Wrexham, Little Mill. I don't know where the Little Mill is. North, I'm guessing. Porthcawl, Holyhead. Awesome. So we've got people from all over Wales again. So welcome. Hopefully you are enjoying these sessions, and they're just a nice little recap. So as before, like I said, we're going to do the second part of the medical conditions. We ran out of time, so hopefully you were involved in the session previously. If not, we're going to put the recordings up onto the training website for you to have a look at. Either today or tomorrow, I'll be uploading those for you. So if you missed it, part one, we talked about the anatomy and physiology of the nervous system, and we talked about the endocrine system as well. So we mentioned convulsions, we mentioned vasovagal episodes, we talked about, what else did we talk about? Help me if you're in the room. What else did we talk about? Endocrine, we talked about the endocrine system, we talked about diabetes as well. Good, someone was listening, Ross has come in, we talked about diabetes. What other neurological system did we talk about? Strokes, yeah, we talked about strokes, yeah, cool. Awesome. TIAs, excellent too, you were listening, amazing, thank you. So today we're going to do the second half. We're going to talk about infections, and then we're going to talk about miscellaneous conditions. So we're going to have a little discussion about drug addiction and alcohol. Then we're going to talk about temperature control and heat-related illnesses as well that you may have come across in this summer or winter, depending on what we're having at the moment. It's very mixed. So let's go on then. What do we know about infection then? So if I was to say infection to you, let's have some little hot topics. What comes into your mind when we talk about infection? Let's have in the chat bar. Fever, sepsis, yeah, cool. Sepsis is a big one. UTI, excellent. Temperature, COVID, yeah, cool, good. COVID is the big one at the moment. What else when we talk about infections? So we've mentioned sepsis, UTI, temperatures, we've talked about COVID. Body's reaction to a bacteria, yeah, good. Pneumonia, yes. We talked about pneumonia in one of our sessions when we talked about the respiratory system, good. So what about sepsis then? What does sepsis mean to you? Blood disorder caused by bacteria. Yeah, cool. Straight in there, Steve. Well done, that's quick. So yeah, sepsis is an infection of the blood disorder, overwhelming reaction. Cool, good. What else when someone mentions sepsis? Hyperactive immune response to an infection. Awesome. Very serious condition. Cool. News score. Okay, cool. News score, that's important. Death, yeah, if it's left untreated or unrecognised, then yeah, it could be fatal. Awesome, good. So let's move on and talk about sepsis. So yeah, sepsis is a life-threatening condition that you guys have mentioned already, and it arises when the body's response to an infection or injury, when we're talking about sepsis, to its own tissues or organ. So it's caused by a simple cut, insect bite, or an infection such as pneumonia, as one of you kind of mentioned. There are other risk factors to it, so you can have it following surgery. Women can have it following a birth of a child as well. It is severe. So severe sepsis accounts for 37,000 deaths per year in the UK, which is equivalent to a top flight football stadium full of people. Not anymore due to COVID, but hopefully that will be coming back for us. But within Wales, bringing it a little bit local for us, so it's 1,850 deaths per year down to sepsis. So it's really important that we know what it is and we know how to recognise it. And it counts for more deaths annually with breast, bowel and prostate cancer combined. Cool, so what is going on there? So you're 5 times more likely to die of sepsis than you are of ACS, so a MI or a stroke. So what it is then, so we know it's down to infection, it's down to potential pneumonia or a wound or insect bite. Whereas a normal infection, we can have it localized. So if we've got pneumonia, it's localized to our lungs. If it is a wound, it's localized to our leg or something, wherever we've got that wound. But when we talk about sepsis, it has developed. So this local infection's developed. Now the bacteria from the infection gets into the patient's bloodstream. That triggers a body's immune system to respond to it. So what happens then? So the bacterial virus is now in the bloodstream. So now it's on our motorway to get around the whole body. So it can leak from our blood vessels into surrounding tissues. So that is not now, it's not local, it's throughout the body. So the bacteria can turn major organs or the immune system to go into overdrive, causing a whole body inflammatory response, which can now lead to septic shock or multiple organ failure. So it's going from a local infection, which gets into our bloodstream, which is now transported throughout the body. That bacteria or virus is allowed to leak out of the bloodstream or blood vessels into surrounding tissues, which then triggers the body's immune response to overreact to induce a whole body inflammation response, which can lead to septic shock. So that is what is going on, illustrated in that picture. So it's not good. We know lots of people die from it. So we need to be able to recognise it. So how we do that, one of you did mention it, is the NEWS score, the National Early Warning Score. So this enables clinicians, yourselves, to calculate the kind of level of risk that patient is under. So it gives us a risk factor or a risk number, which will show what that patient's risk of deteriorating is. And this is a universal score that's used throughout the ambulance service and throughout the NHS in the UK. So the score is calculated through patient's observations that you are able to carry out routinely. So there are a few at the moment you won't be able to do, and the main one there is temperature and blood pressure. But we know, or hopefully you know, that you will be getting those skills hopefully next month. We're just waiting the final go-ahead from our clinical directorate department to allow us to run our CPD this year. And we're going to be rolling out full observations to all of our volunteers out there. So that's good. So you will be able to do it. So, some of you mentioned a NEWS score and NEWS 2. At the moment, in the Welsh Ambulance Service, we're only using NEWS 1, the normal NEWS score. So what it does, it shows both in acute hospital settings and in the pre-hospital environment. It allows you to have trigger points, which gives you and sets the patient into a low, medium or high risk scoring. And that is, so we're looking at score of 0 to 2 is kind of no risk and they're kind of okay. When we're going to a score of 3 to 5, they're in threat. So they've got a threat of an acute illness or chronic illness being unstable. A score of 6 to 8 makes them sick and likely to deteriorate rapidly. And then a score of 9 is meaning they need life-threatening or life-saving kind of interventions. They need immediate action. So they're critically unwell. So we can use this when we are upgrading response from the ambulance clinical contact centre, or you can do it in your patient handover to the clinician on scene. So the actual screening then, as I mentioned, Welsh Ambulance Service uses NEWS. We don't use the NEWS 2 yet, just because paperwork, and we haven't adopted that yet. NEWS 2 just takes into account some other types of patients, such as COPD patients, etc. So it's just an additional kind of scoring matrix to it. But at the moment, we're just using NEWS score. Easiest way to do it is probably an app form. There's loads of free apps out there that you can get, but just to make sure it's NEWS score and it's not NEWS 2 if you are using an app. Or you can have a card, or you can print off the enhanced skills kind of form, which is on the training website. That gives you the NEWS score. It gives you the GCS scores as well for you. So they're the kind of options that you can have. Let me just get some feedback. I'm just going to mute you for a second. There we go. Cool. So the pre-hospital sepsis scoring then. So when we need to identify sepsis or septic shock, there is a criteria that we're going to go down. So first off, they need to have the kind of following presentations. So for a temperature-wise, then we're looking for a temperature of 38 and above or below 36 as one of our trigger points. We're looking at respiratory rate. So if respiratory rate is over 20 or a heart rate is over 90 beats per minute. If the patient is acutely confused or reduced level of consciousness. If they've got a glucose of over 7.7, and again, in the future, hopefully next month, these skills will be rolled out to you. So they're the clinical presentations. So if you've done your observations, at present, if you're not feasibility trained, you can do 3 of them already. So you can do your respiratory rate, you can do your heart rate, and you can do the acute confusion. So if they've got one of those 3, then we need to find a kind of a infection source. So if they've got a history of chest infections or signs and symptoms that indicate it, then we need to look into that. If they've got signs and symptoms of a UTI or a recent UTI in their history, any abdominal pain or distension, so the stomach's a little bit hard, or the patient's noticed their stomach is swollen recently. Any meningitis, which hopefully you'll be able to recognise, any kind of recent surgeries and medical devices, any cellulitis, septic arthritis, any infected wounds. If the patient's had chemotherapy within the last 6 weeks, any recent organ transplant, then we need to consider sepsis. So one, we're looking at the clinical state of the patient, if they've got any of those observations. If they have got that observation and a history of an infection or one of those, then we need to consider them to have possible sepsis. And then again, we need to update control if you are considering it to be sepsis, because we believe that local infections now got into the bloodstream, which has gone around the body's response to it, and the immune system's responding to it. We can see that through those observations. So that is sepsis. What we're going to be looking at now is septic shock. When it's in the bloodstream, it's the body's immune system is overreacting to it and potentially going into multiple organ failure. So what suggests it then? So those signs and symptoms, once again, we're looking for mottled skin. So you've got good pictures of it there. The mottled skin, both adults and children, it's that marble look. If they've got that, they're quite poorly. Something's going on. We're looking at the capillary refill. If it is over 3 seconds, again, we can do it peripherally or centrally, so on the forehead or onto the chest. Systolic blood pressure. So if their blood pressure is under 90, so if you haven't got it and you haven't got blood pressure, then if a patient's blood pressure is under 90 systolic, then they normally will lose the radial pulse. So if they haven't got radial pulse, then you could kind of have an educated guess that their blood pressure is below 90. The rash, so a common rash, again, very late stages, which you can see there, the pictures come up hopefully for you. It's like very much blood-stained rash, but again, hopefully you don't see it because it is a really late stage. And then absent radial pulses, again, that links to the blood pressure. If their blood pressure is below 90 systolic, they will have an absent radial pulse. So what we need to do, sepsis, we know sepsis and shock is on our red list. So we need to give these patients high flow oxygen, 15 litres a minute through the non-rebreathe mask. Treat for shock. And then we need to tell the ambulance crew that you suspect septic shock. And hopefully they would recognise this as well, especially if you've got them on high flow oxygen. Remember, it doesn't matter if their sats are within normal range. If they're on the red list, then you still give them high flow oxygen. It doesn't matter what their oxygen saturation is because they've got a risk of deteriorating rapidly. So all done with the news score. So hopefully you've got a kind of news score in front of you, or you've got an app available to you. So we're going to have a little quiz now. So like I said, 0 to 2 is okay, 3 and above is a threat, 6 and above is sick, rapid deterioration, and anything above 9 is immediately life-threatening, critical illness list. And we've got that suspected sepsis list as well for you. Cool, so some scenarios for you then. So patient A then, you go to a generally unwell patient. They've been, and it's come back through from 111 and they're saying they need a face-to-face assessment, and it comes through to you. Oh, the answers come up as well, which is really annoying. But new score of 9 on that. Hopefully, I think the others will do this as well. No, it doesn't. Excellent. So we've given you the tip for patient A. How about patient B? So patient B, history of it is they've had surgery within the last 7 days, and now they're feeling unwell and called 999. So where you can, try and make a news score and tell me if you think it is sepsis or if you believe septic shock from this patient. So put it in the chat bar, let me know what you think. Give it a guess. If you haven't got it in front of you, give it a guess. If you have got an app or something, then you can use an app. Cool. So Andy's saying yes for red flag sepsis. Okay, good. Do you want to have a guess of the news score? So Ross is coming in with sepsis. Gail is coming in with a news score of 9. Andy's coming with a news score of 9. Roger's saying an 8. Score of 9, okay. 9, 9, 9, 8, 9. Okay, let's have a look. Score of 9. Awesome. Well done, everyone. So yeah, sepsis score of 9, which means they're critically unwell and they've got a history of surgery within the last 7 days, which gives you that infection inlet and source. So yes, we're going to go down through sepsis. Awesome. Next patient then is patient C. This patient's generally unwell, has arthritis, complaining of pain in their joints. And that is the reason for the 999 call today. Again, let's think, is it sepsis? Is it septic shock? And let's produce a news score for this patient. I think our brains all working. What are we thinking? Are we thinking sepsis? Are we thinking septic shock? Or are they okay? Poorly. Okay, yeah, cool, good. Sepsis. Are they on O2? No, they're not on O2. I think it would say if they were on O2. So, likely to deteriorate. What's the history again? History is generally unwell, has history of arthritis, is complaining of pain in their joints. 9, red flag, but not yet shock. Good. News of 7. Okay. Roger's come in with the news of 7. Andy's come in with a news of 7 as well. Cool. Let's have a look. Oh, news of 6. Where's that gone? Let's go back. Cool. So news of 6. So what are we looking at then? So they've got a heart rate over 90. They've got a respiratory rate over 20. So they've got the criteria there. They've got arthritis. They're complaining of increased pain in their joints. So you could kind of produce a infection risk of septic arthritis. So you could go down yes for sepsis, and they are going into the amber list. So they've got the risk of deteriorating quickly. So good. Needs investigations, yeah. Excellent. So you have got it there. So really good. Well done all. Update CCC, yeah, of course. If anyone hits that amber or red, we should be updating our control and our clinicians in control. Cool. Well done, cool. Well done, everyone. So management of sepsis then. Nothing new. We're going to correct any major A, B, C, D, E problems. We're going to give them oxygen because it's on our red list. If we're querying sepsis, then they can have high flow oxygen. Doesn't matter what their O2 is. We're going to update CCC if required. And how you do that is important. So it's up to you what you want to do. If they are critically unwell, you can give them a call. Or if you just think this patient is septic and they have got this risk, then you can text them as well. So feedback from control, they prefer texts because they can respond to it immediately, and it is all recorded on the database as well, or on the control system. What if they have COPD? So the red list overrides COPD because they're more likely to die of sepsis and shock than their COPD, or they're more likely to die of major trauma than COPD. So if it's on the red list and you're sure of it, then yes, it overrides COPD. Cool. And that's what management of CPD is. But what is really important is that observations, these snooze scores, do not substitute to a sound clinical judgment or common sense. You are all clinicians in your own right. So if there's snooze scoring of 3, but they are grey, they're sweaty, they look unwell, then most likely your common sense and your clinical judgment is right there and they're really unwell. So don't always go by observations. Use your gut feeling as well and your clinical judgment if that patient is well or systematically well. Cool. Any questions on snooze score, sepsis, infections? No? All quiet? That's good. So, just a tip. To ask if there's any new injuries. Cool. Yeah. So yeah, a team's just come in there. A little tip to remember to ask if they've got any new injuries. Because if they're phoning that they're complaining of feeling unwell and sick and poorly, then they may forget to tell you about any previous minor injuries or something or spots they may have had. Cool. So miscellaneous conditions then. Lots of conditions you go out to. There's 800 odd conditions that you will go out to. And we protect you from quite a lot. So we try and protect you for maternities, from alcohol or drug related calls. But as you know, you do go to them because it's sometimes if it comes through as chest pain or if it comes through as breathing difficulties first, it goes down to that call code. And you'd only be stood down if there was a scene safety issue that the call taker has been made aware of. So it is important. We haven't really talked about drug addiction or alcohol addiction before, so it's important that we include it in those miscellaneous conditions because you do go to them. So it is important that we do have a slight understanding of it. So drug addiction then. Technically, drug addiction is a chronic disease of the mind, as is alcoholism. It is a chronic disease. They do suffer from it, and it's really hard for them to recover, and sometimes they can't recover. And we're going to talk about that now. So drug addiction is categorized as a compulsive drug taking and complete loss of control when it comes to the taking of the drugs or alcohol. So and we'll talk about why and what's happening in the brain when we talk about that. So initially, any drug taking or alcohol consumption is categorized as voluntary, but repeat drug use or alcohol abuse can cause complex alterations in the chemical kind of balance within the brain. And that is what we're going to learn about or talk about today. So these changes make it difficult to stop taking drugs or drinking alcohol. Powerful cravings kind of take control and make the patient kind of continue to take drugs or alcohol to rise, and some of these kind of withdrawal symptoms can be deadly. So we know seizures and non-epileptic seizures can be down to drug withdrawal because of that chemical imbalance. And we'll talk about dopamine a little bit later and what's going on in the brain that causes these seizures. So these urges can continue for many years after the patient's taken or has kind of taken these drugs. and they kind of get addicted to it. And that's what addiction is, and drug addiction. That's the definition of it. So how it impacts us then, and why do people take drugs? I think it's really important that we have an understanding of drug addiction and why actually people take drugs. So why do you think people take drugs or drink alcohol? Why do you think? There's a few factors behind it, why they do it. To be social, yeah. Low self-esteem, cool. Effects of distress, yeah. Escape. Peer pressure, escape, give them confidence. Abuse, yeah. Financial problems. Peer pressure, unable to cope. Developmental trauma. Cool. Good. So, yeah, there's loads of kind of negative sides of it. Threats. Cool. Okay. So the main common ones why people take drugs. One is they get that feel-good factor, and it increases the feeling of pleasure and happiness each time they take the drugs, and it gives them that positive feeling at a time where their life isn't probably that positive. It can improve mood. So people with stress, with depression, with anxiety, it can take them out of their normal mood and lift it. Improve performance. So pressure in school, work, sports can lead to drug use. So we're not talking about addiction now, we're talking about drug use and what makes people use it. So yeah, pressure in work, pressure in sports will improve their performance, allow them to take it. Genetic factors as well. And then, like you guys said, the social side of it, trying to be social, peer pressure from other people, especially in teenagers and young people, are quite high in this category. Cool. So we know why they do it, and normally they take it to improve their current situation or improve their performance in work. So let's talk about the risk factors then. So what risk factors do you think includes, and who would be at a higher risk of falling to being addicted to drugs? So we know why they take them. They take them for peer pressure, improve that good feeling. But who would be at higher risk? Yeah, cool. So homeless, youngsters, childhood experiences, yeah, adverse childhood experiences, pre-existing medical conditions, vulnerable people, poor family situations. Good, okay. So biology, so 50% of people at risk of developing addictions is down to genes. So they are born with it. So ethnicity, gender, some mental disorders will have a huge factor in them developing an addiction. The environment someone grows up in or lives in or works in. So we talked about why they take it, to improve in performance, and that can be down to environmental pressures or factors. Developmental as well. So if they take drugs that can, at a young age or a teenage age, where they're not fully developed, their emotions and their decision-making part of the brain isn't fully developed. So by taking drugs at a younger age will interfere with their developmental stages and how they develop as an adult. So the younger person takes it, the more risk. Other factors are the family and home life. So if there's history of alcohol abuse, drug abuse within the family, they've got a higher risk. Schools, social circles. So if their friends take it, then they've got a higher risk of going into it as well. So important stuff then. What's happening in the brain for them to do it, and why we kind of need to understand. So the chemical reaction that happens in the brain is the result of why people become addicted to drugs. So the mind-altering substances, such as drug and alcohol, feeds the brain's kind of reward circuit with a chemical called dopamine. So dopamine is something that's released in the brain when we do something that we enjoy. That could be something such as eating. Had some noodles, Chinese for lunch. I enjoyed it, so my brain released a little bit of dopamine to show I enjoyed that, and that will allow me to, or hint me, so next time I go past a noodle shop, I've got that dopamine release and I know that I want to have some more. And that's what's going on with dopamine. So yeah, it's that feel-good factor when you do something pleasurable, such as eating, seeing a loved one, or engaging in sexual activity. Cool. So when the brain functions, when the brain is functioning, the reward system working properly, so everything's normal, it releases dopamine when someone does something pleasurable, which encourages them to repeat that behavior. So by a rush of dopamine, we can have that kind of aura and that feeling of a high, that good rush, which can also motivate unhealthy behavior as well. So if I eat loads of Chinese, I'll enjoy it and I'll repeat that behavior. But if I take drugs, that again has that same effect, then the dopamine can produce or make me take more drugs. And that's what the addiction is. The addiction is the dopamine, that feel-good factor. So it's not that people taking drugs because they like it, it's the brain saying that they need it now because of that sudden overreaction of that dopamine release within that brain. So the more someone takes drugs, the more the brain changes, and the ability to fuel natural reward chemicals to respond to that good feeling good kind of factors. The user or the drug user, each time they take it, it releases dopamine, and that will reduce the brain's foreign kind of reaction to it. So how to explain it? If a patient takes drugs, they'll have that high sudden release of dopamine, which will kind of counteract our normal reward system. So if I go and have something pleasurable for food, then the brain won't trigger it because it's used to the drugs because they have a higher dopamine level. So I hope that kind of understands. So that is what, when someone says they are tolerant to alcohol or drugs, that's what's happening. It is as a result of the decreasing pleasure of foods or socializing. So alcoholics can drink a lot more alcohol than me for a reason, because of that level of dopamine release. So withdrawal then, and the real physical addiction. So drugs increase the amount of dopamine present in the brain. The body reacts to this by producing less dopamine in the brain, which gets rid of the dopamine receptors. When the user stops putting drugs in their body, the lower production of dopamine means that they need to increase or have additional receptors to be inserted, because they're used to having a lot of drugs, so they've got rid of those receptors, they've reduced dopamine release. If they stop taking the drugs, it reduces the production of dopamine, which means they have those withdrawal symptoms because they haven't got the high level of dopamine in the system. So the drugs have made that chemical effect, the change of chemistry in the brain, which is the reduction of receptors, reduction of dopamine being produced. So if they take that external drug use out, then the brain's chemistry still needs something. So for drug addiction, the initial low levels of dopamine results in the patient losing or almost losing the complete lack of pleasure. So dopamine is the main pleasure or neurotransmitter. So no dopamine, no pleasure for that person. So this is kind of an illustration of what I've been talking about. So with food, Chinese, I enjoy it, dopamine is produced, it's sent out, and my brain kind of identifies it as good. When we take a drug or alcohol, that gives us a sudden rush of dopamine within the brain. That means the brain kind of gets rid of those transporters, those receptors, and we have less dopamine being produced. So if we take away that drug, then we've got the brain is used to having so much dopamine. It's got rid of it doesn't have normal pleasure from eating or activities anymore because it's used to having that high level of drug use. So if we suddenly take away that drug use, then we have those withdrawal behaviors. And we know dopamine is really good at making our behaviors change and allow us to want to do certain behaviors more. So that is what's going on in the brain. The chemistry's changed. High levels of dopamine is used to. By suddenly stopping alcohol or drugs, and they suddenly stop the high dopamine use, so their withdrawal symptoms will kind of increase because the brain wants more dopamine, which it cannot produce anymore naturally. Does that make sense to people? What is going on? Or have I just waffled? What's important is it is a chronic disease. It's not just they're taking it voluntary. They've had it for a while. That has made a chemical change within the brain, with receptors being taken out of action and not producing dopamine. So there is a physical change, and the symptoms they are showing is down to that chemical change within the brain. So addiction is a real thing. Alcoholism is a real thing. Useful to share the need rather than people just choosing to. Yeah, good, excellent. Yeah, so it is the need. It's not them choosing to continue to drink, choosing to continue to take drugs. It's the need because of that chemical change. So it's really hard for people to change addiction without further help. Cool. So management then of overdoses. If they're unconscious, we're just going to do our A, B, C, D, E approach, option therapy if required. If they're conscious, again, A, B, C, D, E approach, option if required, but it's important to gain a history from that patient, what they've taken, when they've taken it, the time and how much they've taken. And again, if needed, we can cascade that to the crew or back to CCC if required. Ooh. So last little bit is about hypothermia. So introductions. We know the body's really good at regulating temperature, and we can have a good range. We like to stay at 37, but anything 35 to 38.2 is kind of the range that we stick at. So thermoregulation is down to that job of the hypothermia, kind of down in our bottom part of our brain, that control center. So sensory information is sent from the peripheral and central nervous system, and this allows us to protect vital organs. So the core consists of organs within the skull, thorax and abdo, and then when we're talking about the shell, that's our limb and skin. So by controlling blood flow to our shell, the skin and limbs, our hypothalamus can control the amount of heat lost or gained, kind of thing. So if we're really hot, then our skin gets flushed because we're trying to lose that heat. If we're cold, we peripherally shut down to bring heat back into our shell, into those vital organs. So how we assess temperatures. So a rough estimate is just feeling them. If they're very hot or very cold, it's not accurate, but in the next few months when we roll out the CPD, we're going to be rolling out tympanic thermometers to you, which will give you a more accurate reading. So hypothermia then. So hypothermia occurs when the body's temperature falls below 35 degrees. Common symptoms are the kind of mild shivering, and then it can progress down to cardiac arrest, and they go up unresponsive, stop breathing. So mild, moderate and severe then. So what temperature do you think we're going to hit at mild then? We know it's below 35, but what are the three categories? Anyone know? Anyone want to guess what mild temperature would be? Yeah, awesome, spot on. 32 to 35, good. What about moderate? (28 to 32), 28 to 32, awesome. Excellent, and then severe below 28, good. Again, at the moment you can't really check, but when the tympanics come in, we can now identify if it's mild, moderate or severe hypothermia. So what conditions would make someone more prone to hypothermia, do you think? What people? Yeah, little people, yeah, children. Drowning, yep. Elderly, especially over 85, babies, elderly. Good. So yeah, our older patients, our younger patients, patients with certain medical conditions, our intoxicated patients, patients under alcohol and drug, drowning, like someone said, exhaustion, our injured or immobile patients, and then those patients with a decreased level of consciousness. So if you think of it, all these patients can't really warm themselves up because of certain conditions that they've got. So hypothermia will hit them and they'll get colder more quickly down to these conditions. So how does it progress then? Down to the 5 stages. So first stage, that is conscious and shivering. When we get cold, we start shivering. That is our body's automatic kind of system trying to warm us back up. What is the next stage, do you think, from hypothermia? What's the next severe stage after shivering? Stop shivering, yeah, cool. So decrease of level of consciousness and they've stopped shivering. So if you go to a patient, family say, oh, they've been really cold, shivering all day, but now they're a little bit more confused and they've stopped shivering. That doesn't mean they're getting better, that means they're probably getting more cold. Then we're going to progress to unconsciousness, and then after that it's pretty bad. So not breathing, and then death due to a irreversible cause of hypothermia. So it's important that we recognise it. Conscious, shivering, they're getting cold. Let's prevent them from getting worse. If they've got a history of shivering, now they're getting confused and stopped, then again, let's warm them back up before they get to any further stages of hypothermia. So how do we treat it then? What kit do you have? Blanket, yeah, good. Hat, yeah, hat's good. We lose a lot of heat from our head. Blanket in the kit, good. So we have got blankets. So please make sure you do have a blanket in your kit. We like the old school blankets. Let's not get these foil blankets, because foil blankets can do the opposite effect. It can keep cold in and keep heat out. So you wrap someone up who's cold outside, wrap them up in the foil blanket. You keep them cold, take them into a warm environment, but they're wrapped up in this foil blanket, which is repelling the heat from the warm environment and keeping the cold from that patient. So blankets are better than the foil blankets. So please make sure you have got one. And think in the home environment as well. So being on the floor, you've got a faller, they are injured and you can't get them up. They are going to get cold, they are going to get hypothermic, so let's get their duvet from upstairs. Let's keep them warm when you're waiting for the ambulance crew to arrive. So the most important thing when we're talking about hypothermia is to prevent any further heat loss. Then we need to move the patient to a warmer environment or remove wet clothes, like some of you have mentioned. Oxygen, if it's hypothermia, because hypothermia is on the red list. Our SpO2 sensors will not work on a hypothermic patient because the body's hypothalamus, the little temperature regulator, has taken all the blood supply out of our shell into our vital organs. So our hands will be cold, reduced blood flow, so our SpO2 sensors will not work. So if they're hypothermic, they have high flow oxygen. And that's one of the main reasons why, when we're talking about RLNI, if you join that group this morning and that session, where the RLNI will give high flow oxygen all the time, because most likely the patient will be wet, they will be cold, and saturations will not be accurate in that environment. So that's why we bring them back to shore, then reassess them then. But for hypothermic patients, they have high flow oxygen, 15 litres. Wrap them up in a blanket. We can give them hot food and drink if they are conscious, but no alcohol, because it gives us that negative effect. Avoid any rough handling, because hypothermia, again, when it gets to those stages of 2 or 3 or 4, then arrhythmias, when it affects that heart muscle, that can take effect. And if we have rough handling, we can cause or make arrhythmias worse and potentially cause cardiac arrest. So let's keep them cool, avoid any rough handling of these patients. With patients of decreased level of consciousness, we should not encourage these patients to walk. Let's manage them horizontally flat on the floor. Let's not try and move them or have rough moving of these patients. And that is it. So, Diolch, thank you all. I hope you have enjoyed these sessions. Oh, yes. Do you want to say hello to the group?
Can't see me.
They can't see. Come in, look me closer.
I can't, I've got a mask on, I can't.
Well, Glynn's just walked in, everyone.
Afternoon, hope you're all well. Happy Easter, hope you haven't had too many eggs.
Cool. So, anyone got any questions? Cracking, good, excellent. So, I hope you have enjoyed these sessions. Nice little hour bite size. We are happy to put them on if you think they are good. So if you do want any extra sessions, then just give one of us an email. We can put a session on. There's no problems with it. But yeah, well, that is 15:59. Can we still do BLS? Yeah, of course we can. I'll put another date up and I'll put it on the Facebook and WhatsApp groups next week or the week after, and put that one on for us as a recap. Awesome, cool. So let me stop recording.